Emeka Ibodike. I'm a consultant, obstetrician and gynecologist from the Premier Specialist Medical, Victoria Island, Lagos. On the lecture, we'll be discussing the management of male and female infertility. The learning objectives, we'll be able to define the terms in infertility, then classify infertility, how to evaluate couples with infertility and how to treat couples with infertility. Then we look at different fertility options. The expectations of learners at the end of this lecture is to understand the definition of the terms and also to comfortably classify infertility and to learn how to evaluate and manage couples with infertility, then to learn the different treatment modalities. Infertility is ranked the 5th highest serious global disability among populations under 60 years of age. And this is actually the World Report on Disability and World Health Organization and World Bank in 2011. The males and females contribute equally to the cause of infertility. And these causes can actually be preventable and some can be non-preventable. It's important to know that sometimes the international aid feels that in sub-Saharan Africa, giving aids for infertility does not justify because we still are among the people that have the highest fertility rate when we compare to other cohorts worldwide. Infertility is defined clinically as a disease of the reproductive system by failure to achieve a clinical pregnancy after 12 months or more of regular unprotected sexual intercourse. This definition is by International Committee for Monitoring Assisted Reproductive Technology, 2009. Other definitions by the Semen Manual of 5th edition 2010 say that it's inability of sexually active non-contraceptive couple to achieve pregnancy in 1 year. Other definitions, some define the inability to achieve and sustain a pregnancy to delivery after at least 1 year of regular unprotected penetrative and ejaculative vaginal sexual intercourse with an adult of the opposite sex. It's important to have all this put in the definitions because we have the issues coming up, and so one must be able to highlight all these important keywords. Subfertility can be defined as a special case of infertility when there are deliveries but not having any or desirable number of children alive. Unexplained infertility can be couple and or individual have no discernible cause of infertility after a comprehensive investigation of tubal assessment, ovulation assessment, seminal fluid analysis, and postcoital test after 2 years of regular and unprotected sexual intercourse. Note the word 2 years there. Then regular coitus can be defined the average of coital exposure of at least 3 times or more on most days per week. And this coitus must be unprotected. For demographic definition of infertility, inability of those of reproductive age group, WHO defines the reproductive age group as between 15 to 49 years. Some literature will write 15 to 44 years. To become or remain pregnant within 5 years of exposure to pregnancy. Remember, this is demographic definition. And this is demographic report number 9. Trend of prevalence, we define infertility as inability to become pregnant with a live birth within 5 years of exposure based upon a consistent union status, lack of contraceptive use, non-lactating, and maintaining a desire for a child. All these keywords will come into play each time we are defining infertility. Classification, it can either be primary or secondary, where a woman has not delivered any child at all. One can say it's primary. And when the woman has delivered, but following either a previous pregnancy or previous ability to carry a pregnancy to a live birth, so that means that this woman has delivered, but the points that are highlighted are actually missing then one can say that that is actually a secondary infertility. For other definition of terms, fertility in itself can be a capacity to produce or the state of being fertile. Fecundability, which is about 0.2 to 20%, is a probability of achieving a pregnancy each month per cycle attempted, while fecundity is the ability to achieve a live birth within one menstrual cycle. Reproductive age group that is affected globally is about 10 to 15%, and couples about 5 to 20 world over. And the truth of the matter is that the prevalence has been actually stable over the past 50 years, and about 1 to 5, 1/5 of every couple in Nigeria have difficulty with conception. But the paradox is that infertility is more prevalent in regions with high fertility rates, like Nigeria. And we're going to see that when we look at the Nigerian NDHS 2018, which is the latest. Infertile women are more likely to be less educated and non-contracepting. So they still fall into the group that they don't really go to school, yet they still produce a lot of children. Now, the total fertility rate, according to that published in 2018, that's a mistake. This is the average number of children a woman would have by the end of her childbearing years if she bore children at the current age-specific fertility rate, which is defined as calculated for 3 years before the survey based on detailed birth history provided by the woman. So if you look at this, the total fertility rate as of 2018 is 5.3. That means, of course, demography, there is nobody that is 0.3, but that means 5. So each family will have at least 5 children. That's a lot. And yet, we still have burden of infertility. So it's a bit paradoxical. This is a chart, the graph showing a decline, and there's actually a plateau around 2003-2008 about a total fertility rate in Nigeria, but in 2008 it has actually fallen. But as of 1990, it was 6 children per family. That's a lot. We said earlier that male and female contribute equally, and unexplained is about 5 to 10% of cases. As the woman ages, it is good to recognize that the fertility tendencies tend to decrease. And as of more than 36 years, about 50% potential, that is pregnancy rate per age, it drops. You can see less than 30, about 70 to 75%. Let's look at the etiopathogenesis. It can either be a female factor, male and female factor, or unexplained factor, as we said earlier. For the female factor, it can affect the tubes, the uterus. It can be based on inability to ovulate, endocrine, the affectation of the cervixes, endometriosis, unexplained. For the tubal factor, which is the commonest, in fact, up to 50 to 60% of cases is based on tubal factor infertility. And of course, in sub-Saharan Africa, where it's very common, it is based on practices such as puerperal sepsis, sexually transmitted infections, and post-abortal sequelae. So this has heightened these particular incidents. Adhesions post-surgery, most of the surgeries are badly performed, and that can lead to intraperitoneal adhesions, which can lead to peritubal adhesions too. Endometriosis, especially the moderate and severe forms, can also lead to adhesions, intraperitoneal adhesions, and these can impair fertility function. Uterine factors like Asherman syndrome, congregation of hypomenorrhea, menorrhea, having uterine synecdoche, and sometimes cervical synecdoche, and this woman having infertility is also can contribute up to 50% of cases. And uterine anomalies are also there. Then for the anovulatory factor, commonest is the polycystic ovary syndrome, which is also a prominent problem which can make a woman not to produce eggs for fertility to occur. Hyperprolactinemia is also among the anovulatory causes. The endocrine causes can also, the cervical causes, cervical hostility. Then endometriosis, especially the mild ones may not necessarily have features that present with intraperitoneal adhesions. But there are, for some unknown reasons, mild endometriosis can actually be a cause of infertility, and such women may actually benefit from artificial reproductive technology. There are other unexplained factors, especially when one has tried to rule out the fundamental cause of female factor infertility and the woman is still not getting pregnant. Such a woman can actually be classified under unexplained infertility. For the male factor infertility, we can classify into the pre-testicular, testicular, and post-testicular causes. And for the pre-testicular causes, there are many of them, but among them are the endocrine, the Kalman syndrome, usually anosmia, problems with the hypothalamus, pituitary failure, surgery, radiation, thyroid diseases, and androgen pills. Nowadays, especially in the Western world, where men use a lot of androgens for gyms, without knowing that that can actually has a problem with fertility. The coital problem, erectile dysfunctions, and ejaculatory failures are also primary as a cause of pre-testicular male infertility. Testicular causes can be cryptorchidism, where there is the testis fails to descend into the scrotum. Therefore, the temperature there is definitely not adequate for spermatogenesis to occur. Mumps orchitis, especially happens in the childhood. That can also lead to testicular causes. The Cartagena syndrome has to do with the wafting system of the mechanisms that allow the sperm to move, from the tail. So if that is affected, that means the wafting and movement may be impaired. Then vascular problems like varicocele and torsion. These are all problems that can also affect the male infertility. For the post-testicular causes, the anatomic causes and non-anatomic and immunologic causes. Immunologic causes can be post-vasectomy. Post-vasectomy, there can be some formation of immunology against the sperm cells post-vasectomy. So it's important to note that, and that is also should be monitored for in those patients with post-testicular causes. The non-anatomic are the epidermal hostility, which can have a combination of, or possibly most of the time we have acinospermia. Then anatomic is epidermal vas difference, like we said in the drawing, in the pictorial representation. So epidermis, vas difference, all these can be affected. There can be obstruction here or there. So all these can lead to the post-testicular causes. And of course, we said it is absence or obstruction. So you can have the absence of the epididymis or absence of the vas difference. This can be the cause of post-testicular causes. Let us look at the evaluation of infertility. It's important to look at the history. History of the couple. Remember that the treatment of infertility is central. It is couple-oriented, not just the woman or the man. It's both of them. So biodata should be taken. Age is, remember we said age factor can be quite central, especially for the woman because of the ovarian capital. Then the religion is also important. If a woman is a Roman Catholic, remember the beliefs system, which we are going to look at under the controversies or ethics in infertility, in terms of the management they're going to offer her. Then it's important to look at the last menstrual period. I mean, if the woman is already amenorrheic and you are investigating for fertility, that doesn't make any clinical sense. So that will guide you whether the woman has issues with menses or whether the woman is already pregnant. If the woman lives with husband, it's very, very important. There is no way we'll be talking about definition of infertility and couples are living apart. It's difficult because we said at least a year. At least a year in those less than 35 years, but for those more than 35 years, you may have to do that maybe within 6 months because of age factor. But the issue of allowing 1 year is at least to ensure that couples that are copulating 1 year is enough because we're going to look at the percentage percentage possibility of getting pregnant per cycle, that is at least for 6 months, 1 year, 2 years, and afterwards. That is very important. Coital frequency is very important, and it must be penovaginal. It is important. We've seen cases whereby couples are presenting for infertility and they're not actually having penovaginal coitus. That is, if that is actually it comes up, that can be solved by counseling, and that can actually be the only treatment modality. The spouse, is it a female-male companion or female? So one can actually know how to cancel at this particular point, just at this opening statement. Then adopt a head-to-toe approach. Whether she has headaches, acne, facial hair, that might still be in keeping with possibility of anovulatory factor infertility, blurring of vision, recent weight gain, neck mass, thyroid diseases, heat and cold intolerance might still be pointing to work at, which of course ovulatory again, nipple discharge, possibility of having hyperprolactinemia if she assesses the abdominal masses, fibroids. Whether she has fibroids, again, there is also a debate about fibroid and infertility. But of course, we know that when fibroids are located in both corners of the tubes, that can become quite central of the cause or possible cause of this, which can either be causal or casual. Then the menarche, at what point did this lady achieve menarche? That's the first time she sees her menses. Is important. Was it delayed, or has she not even seen it at all? That will point towards secondary sexual characteristics, regularity of menses, menorrhagia, dysmenorrhea, sexually transmitted infections, and contraception use. We have seen the cases of couple coming into the clinic and the woman has intrauterine device and they want to conceive. So if we discover that, we just simply remove the intrauterine device and the woman gets pregnant. For the husband, it's important to ensure that she has adequate and sustained erection and the ability to ejaculate. Her history of childhood mumps or mumps can actually be gotten. Usually we say the child with full cheeks, and that's very, very important because that can affect spermatogenesis. The occupation of the man, if a man is a radiographer and has been exposing herself without using the necessary protective gowns, it's important to note this. Tight nylon fitting pants. Then the nature of the job. Is he a long distance driver? It's important to know that because that can have some heat under the testes. Chronic illnesses, sexually transmitted infection, post-gonococcal infection can actually lead to stenosis of the tract, the reproductive tract in the males, and of course that can actually lead to a problem with the post-testicular infertility. It's important to actually ask the patient about the investigation they have done so far. There is what we consider are the 3 basic tests of infertility. There are so many investigations, but at least it's important to know, has she done, or has the couple, now the male, has he done the seminal fluid analysis? As simple as that is, that can just be quite revealing. For the female, it's important to know whether she has done hysterosalpingography or laparoscopy or hysterolaparoscopy or dye test where the finance is not the problem. And it's important to also know whether she has done the test of anovulation, at least mid-luteal phase progesterone. These 3 enough can dictate almost up to in excess of 90% of cases the reason for the infertility. So fertility drug taking so far is important. Some of the women were taking clomiphene because they have heard from the friend. It's important for you to know, or whether she's on some herbal drugs that's even toxic or even counterproductive to the fertility she's looking out for. Physical examination for the males is important to look at the stature of the habitus, the ratio of the length of the upper body to the crown of the head to the pubic symphysis to the lower body, or versus the pubic symphysis to the crown of the foot. If one is getting a ratio that is less than 0.92, this may be suggestive of a unicoidal build. And of course, arm span is greater than 3 centimeters, more than the height. Again, this is also in keeping with, and one must note that very carefully. Look out for secondary sexual characteristics, the nature of the hair, how sparse, how full, and you can classify this male. Scrotal sacs must be examined. For those that have scrotal surgeries, it's possible that you can have scrotal surgeries and there can be some complications. The size of the testis must be noted, and also the volume, consistency, and the position, and of course the varicocele. The length of the adult testis must also be measured to ensure that we're not dealing with micropenis. Classification of varicocele is noted, and of course, that as grade 3, which is classified as large, the veins can be seen through the scrotal skin, and one can classify that as bag of worms. For the females, it's important to look at the body mass index, as well as the male is also important. Of course, the weightier, for obese and overweight, there's a possibility of having anovulatory cycles. So one, then acne. Remember what we said during the history taking. The visual field assessment, with the help of the ophthalmologist, that can be assessed for those that have pituitary tumors that can be compromised. Thyroid examination is important, and the breast examination too, looking for a specific galacturia, which may be a pointer to possibility of hyperprolactinemia. Abdominal examination, look out for fibroid and previous surgical marks. And vaginal examination is also important. Body hair pattern is also important. For the investigations, we said earlier that it's couple-oriented and it's also time-bound, and it should be active. So it's important at this point to first of all counsel the patient that they need the full cooperation of the couple, because each day is representative of a particular investigation. For instance, day 1 to 3, the husband's seminal fluid analysis is taken. It's important that day 1 to 3 is chosen because at this point it's expected that the woman will still be menstruating, and that of course will discourage the husband from having coitus with the wife. However, the husband has to also be counseled not to have coitus any other place that is not necessarily the wife, because the essence of concentrating the 72-hour or 24 to 72-hour concentration is very important to be able to have a profile that is representative. Okay, the day 7 to 10 hysterosalpingography should also be requested to look at the tuber patency for the woman, and of course the mid-luteal phase progesterone to look at the ovulatory factor infertility. Offer this investigation, we said earlier, that after a year of unprotected regular coital exposure. We have defined what regular is. Spontaneous pregnancy can be achieved in 75 to 80% of cases within 6 months of cohabitation, and spontaneous pregnancy in 90% within 1 year. In fact, in excess of 95 after 2 years. Early investigation for more than 35 years, we said earlier, should be considered. Some has recommended at least 6 months. The tree-based investigation can unravel, we said earlier, up to 85 to 90% of cases. So it's important to ensure the tree-based test before doing other high-falutin tests. Ensure to complete the test within 1 menstrual cycle. Aim at treating the affected couple in the next menstrual cycle without necessarily jeopardizing the fetal life, peradventure the woman conceives. The mainstay of male infertility is seminal fluid analysis. We have said it, and it has up to 90% of true positives. But however, it has about 10% of false positive tests. So, where there is false positive test, repeat testing can reduce false positive testing to up to 2%. So, now this repeat testing can be done at least 3 months afterwards, so that to allow the spermatozoa, the cycle to take place. But however, if the patient has azoospermia or oligospermia, it is advised to do this testing earlier. Some have said 1 month, some said 2 months, but it should be done earlier because you need to treat. And this assessment must be done in the same laboratory to ensure quality control. Tuber patency testing done within day 7 to 10. Some we talk about the day 10 rule, ensuring that the woman is not menstruating at the point this is done. This is very important testing and is quite cheap. In fact, the studies have tried to compare hysterosalpingography with hysterolaparoscopy and dye test. I discovered that in terms of monetary evaluation, the hysterosalpingography is 3 times less the cost of hysterosalpingography and dye test. So, but however, where there is money is not the issue, one can also do the test because one can actually has an advantage over the other, but both are necessarily complementary. The test for ovulation usually done in day 21 for a 28-day cycle. Usually we call it the mid-luteal phase progesterone, is representative and can show a woman that is actually ovulating. Once this test is done, you can follow up. Other ancillary tests that can be done can be day 2 to 3, follicle-stimulating hormone, luteinizing hormone, prolactin, free testosterone. These are the hormones that can be done, and all of them are pointing towards the woman is having an ovulatory cycles or ovulatory cycles. The semen fluid analysis is evaluated currently by the World Health Organization Semen Analysis 5th edition, that's 2010, which modified the previously used 1999 model based on the findings. And these findings are less when compared to the 1999 model. For the semen volume is about 1.5. That is, we are looking at the reference limit. There's a reference limit of 1.5 to 1.7. And the sperm number has dropped up to 39, concentration dropped to 15, motility to 40, progressive motility to 32, and vitality to 58. We used to be 75. So there is a drop. Morphology is now 4%. So these are, which used to be 50. So these are all drops, and this is actually encouraging. So with this, a lot of men will be branded to be fertile and not necessarily infertile because of the modification of this result. This is just using the profiling. Then the pH should be less than 7.2. Okay, then abnormalities of seminal fluid analysis are many, but not limited to this. Aspermia, azoospermia, hypospermia, oligospermia, teratospermia, and astenospermia. There can be a combination of the three: oligo, terato, astenospermia. These are all abnormalities of seminal fluid analysis. For the evaluation of female infertility, for the tubal factor, we'll talk about the issue of the 10 rule. There are other things that can be used for tubal factor evaluation. Is the sonohysterosapilography, which gives a better picture, especially when there are endometrial lesions, like fibroids that are just the one that are submucous fibroids. Sonohysterosapilography can define that very beautifully. Hysterolaparoscopy plus dye test is also very good. Some literature will say that it is superior to HSG. Most of literatures will say that they are complementary. Tubal catheterization can be done, and of course, which can be used as a form of treatment too. Other tubal factor evaluation is transcervical falloscopy, selective sapilography, and fertiloscopy. For the women with amenorrhea, the assessment, whether they are amenorrheic, oligomenoric, or regular menstruation, perform a pregnancy test. Like we said before, when you ask the woman for the last menstrual period, that will give you, because for every woman that is within the reproductive age group, which I have earlier defined, one that is amenorrhea, you can say that the woman is pregnant or proven otherwise. However, if the amenorrhea is not due to pregnancy, so first thing is to perform a pregnancy test. So if or that the woman is oligomenorrhea, so having a period between 21 to 35 days, or the menstruation is regular, you have to establish this at the first time. Then we can now consider the progesterone challenge testing. When this is done, and also to look at the 2 FSH, LH, E2 prolactin, that's estrogen, then prolactin and thyroid function test when necessary. If the follicle stimulating hormone is reduced and there is no withdrawal bleeding after giving progesterone test, one can classify this as group 1. So, for if the normal follicle stimulating hormone is normal and there is withdrawal bleeding, you can classify that as group 2. If there is increased follicle stimulating hormone and there is no withdrawal bleeding, you can classify as group 3. And if there is increased prolactin, you can classify as group 4. So these are how the way the WHO has tried to make this classification. And beneath, you can see the management protocol for each. For group 1, can advise them for weight gain, let them reduce their weight. Then they can treat them with gonadotropins. Weight reduction, anti-estrogen, gonadotropin, over-reducing can be group 2. Then donor eggs, dopamine agonist surgery for group 3, and dopamine antagonist and surgery for group 4. For treatment, for male treatment, it's important to mention that male infertility, the role of the urologist cannot be overemphasized. We usually talk about multidisciplinary. It's not just the gynecologist. The urologist should be, involved in case there is, places for surgery. For male, it's important to discontinue the offending agent if possible. For instance, if a man is on anabolic steroid because he wants to exercise, tell her that this might not be good for him. If he does smoking, he should stop smoking. Alcohol, he should stop, reduce alcohol intake. Treat infections, cancer-current infection when necessary. Augment erection to achieve ejaculation. For instance, you can use sildenafil citrate. Consider prostate massage for those that have spinal cord issues. prostate material can actually lead to some element of augmentation of erection. Consider vasectomy for obstructive causes. Remember, we said the urologist, a role cannot be emphasized, and also the retrieval form of semen, of sperm, can also be done by use of the artificial reproductive, which we are going to talk about in the later lectures. The intrauterine insemination can also be done with husband or donor semen, depending on the indication. And the intracellular sperm injection can also be done, and of course, the popular in vitro fertilization with embryo transfer. These are all artificial reproductive can be offered for male infertility. For the uterine factor, it's important to know that those with Asherman syndrome can benefit from hysteroscopic synechiolisis and the placement of intrauterine catheter. And of course, after that, when the patient can now go ahead and have other trial of pregnancy. Unification surgery, uterine surgery can be done for embryological problems with the uterus, where they have a transverse septum. That can be, the surgeries can be done. And uterine transplant has also been done in few subjects, and which has been good, even though it's not well popularized. Open laparoscopic, hysteroscopic, or hysterolaparoscopic approaches to uterine fibroids can also be attempted. Remember the controversy we said earlier about fibroids and infertility. For the cervical factors, treat cervical stenosis and follow up with hysteroscopy. Postcoital or Sim-Horner's test for cervical fertility can be done. Remember that Sim-Horner's test is also advocated, especially in sub-Saharan Africa, where some husbands believe that infertility is a woman thing. So one can use Sim-Horner's test to actually assess the semen quality, and of course, and some parameters. Unexplained infertility, other advanced testing can be done for that. Remember, we said the basic 3 infertility. Now, there are other advanced tests that can be done: antibodies to sperm, zonal pellucidal testing, mild endometriosis, real laparoscopy, luteal phase defect, defective, all these integrin levels, they can be done. They are high fidelity, but they are possible. For the ovulation induction treatment, that is for those that have ovulatory factors, discover the cause of that ovulation and guide treatment. Life modification, if the woman is in terms of overweight or obese, it's advised for them to lose weight. Anti-estrogen can be used to achieve ovulation induction, clomiphene, tamoxifen, and this medication can actually be graded. One of the drawbacks of the use of clomiphene is that as the drug dose is being increased, there's a possibility of having effect in the cervical mucus, which can be taken. So one should remember that to give estrogen creams as when necessary. For dopamine agonists, bromocriptine can be used, and carbagolines. Sometimes bromocriptine can have a lot of side effects, but when the side effects are becoming overwhelming, it can switch to carbagolines. But you must know that carbagolines are more expensive than bromocriptines. Gonadotropins can be used, and gonadotropin analogs, aromatic enzymes, aromatase inhibitors. Then laparoscopic drilling is also another well-documented intervention that can be used to actually encourage ovulation induction. Now, before now, we used to talk about 4 holes. Usually, people can put up to 6 holes, depending on how convenient. But what's important is that to ensure that the holes are well placed apart, and of course 40 wide or 40 second 4 millimeters. Most of the time, women can achieve ovulation. Let's look at a little bit on assisted reproductive technologies. Usually, we say that it includes all fertility treatment in which both the eggs and sperm are handled. They do not include treatment in which only the sperm are handled. Only, for example, intrauterine insemination or ovulation induction without the intention of egg retrieval. Artificial reproductive technology includes intravitreal fertilization, intracytoplasmic sperm injection, donor insemination, and egg, up to, there are so many. Remember that Louis Brown in 1978 was the first baby to be born with intravitreal technology in UK by Edward R.G., Nobel Prize winner in medicine. And in Nigeria here in 1984, our own baby Hamaitu was born by the Giwa Sage et al. These are different forms of assisted reproductive technologies, and the frozen embryo transfer. Embryo is also one of the auto minus 196 degrees Celsius in the nitrogen storage. These are all different assisted reproductive technologies. The IVF is usually in 4 stages: control ovarian hyperstimulation, oocyte retrieval under transvaginal guidance, pregnancy with sperm in vitro, and the embryo development into the uterus. There are other treatment modalities apart from what we have mentioned. Adoption is one of them. When a situation whereby a woman has been counseled about all the other options of treatment and she does not want them, or she does not fit categorically into this treatment protocol, she can be offered adoption. It's a practice whereby an individual assumes parenting for another, and in so doing, permanently transfer all rights and responsibilities, along with affiliation with the biological parent or parents. It can either be closed, confidential, secret, or open. Then, another treatment modality is surrogacy, the arrangement whereby a woman carries and delivers a child for another person or couple. It can either be traditional or gestational. We mentioned also uterine transplant, especially for those that has absolute uterine factor infertility, like the Mayer-Rokitansky-Kosa-Hossa syndrome. The report of a live birth following a transplant was in Sweden. So far, about 18 live births has been reported. About 17 were from live donors and 1 from deceased donor. Tubal surgeries can also be offered: neosalpingostomy, fibroplasty, and anastomosis. But the patient must be educated and counseled that some of these tubal surgeries may predispose the woman to have risk of ectopic pregnancy in future, but it is not absolute. There is also tubal transplant has been tried, but it's still historical. It's not successful so far. Cohen et al. Reported in 1980 about tubal transplant. Ovarian transplant can also be done, has been done. In the first that was done was by Dr. Silva, reported by James Randerson in 2008. And this was published in Guardian CO and in UK. Used a 15-year-old woman with ovarian failure, and the donor ovarian was her twin sister. It was done by laparoscopically, and patient later saw her menses 3 months post-op at age of 22. Let's look at the complications of artificial reproductive technology. There are quite a lot. Risk following the drug use, OHS says, risk following egg retrieval, bleeding, anesthetic risk associated with pregnancy, multiple gestation, risk of pregnancy leading to abnormal baby. Because of micro manipulation of the environment, there's a possibility of leading to imprinting errors in this. So this is part of the counseling that was given to the woman during the time we want to offer her artificial reproductive technology. The ethical dilemmas in artificial reproductive technology or infertility as a whole is in vitro fertilization treatment for a married couple. People are asking questions on what basis should we be treating people that are unmarried. I mean, there is no legal term. Why are you doing that? That has been an ethical dilemma. Then treatment for single parents. So who is now the husband? These are the questions that have been asked. Then treatment of the same-sex couple. People have opposed this, both religion, both moral, are opposing. Why will you be treating? Because that means sex couple, that means they might need, so it's a bit, but these are ethical issues. So some people are for, some are against. The pre-genetic diagnosis and screening are not 100%, and may result in viable embryo being discarded. This is what people are saying. And surrogacy may lead to commoditization of the whole process. That means you can pay a woman to carry a pregnancy. People are not very happy with that. I even said that it can actually lead to the exploitation of women. In fact, currently it's said that it's possible to have a child that has 5 parents. That is the genetic mother, the genetic father, the rearing father, the rearing mother, and gestational mother. So this can cause a lot of confusion. Islam does not accept third-party donor egg, sperm, embryo, surrogacy as part of intravesical fertilization. Roman Catholics objects intravesical outright on several grounds, and they believe that several embryos are created and frozen. So what happens to all those ones that are thrown away? And of course, that it disrupts the technical union rather than specific act of conjugal union. Let us summarize this lecture by saying that infertility is a disability. If you have seen a couple that does not have babies, that home is not a very good place, because they are, so that is what head organization said, that this is not just, it is a disability in itself, and don't ever forget to counsel such a couple. Diagnose after a year or regular unprotected coitus, though you can do the earlier diagnosis for those that are less than 35 years. We've said 6 years 6 months is possible for you to go ahead and offer evaluation. Offer the third basic test upon presentation, just the 3, then others if need be. Treat, but offer assisted conception or assisted reproductive technology early enough is important, because most women will just be rigmaroling, and by the time they are being offered assisted reproductive, it's either that their eggs are the ovarian capital has diminished, they can't use their egg anymore, and most of the time they are not very happy. Respect ethical concerns. So if a woman is saying based on ethical ground that it cannot affect your treatment, don't feel bad about it. Just cancel the woman and give her other options. Thank you very much for listening.